John.
Thank you, Mr. Chairman, Co-Chairman, and members of the committee for allowing us to come and present to you today. I'm John Rafool, President and CEO of White Memorial Medical Center. It's a 350-bed facility located in the neighborhood of Boyle Heights in East Los Angeles. We're a couple of miles from the county hospital. We've been around for 102 years, since 1913. We're a faith-based organization, not-for-profit, and teaching institution. We operate roughly about, we operate 4 residency programs. We train 70 physicians a year, also train nurses, as well as allied health professionals as well. Our system, Adventist Health, runs 21 hospitals on the West Coast of the United States. I personally have been at White Memorial for 27 years in different capacities. The last 5 years were pretty challenging for us as healthcare reform is taking hold, and we had many changes occurring in the health industry. However, I have to commend our legislatures for the work that you've been doing, and today we have more Californians being insured than we ever had in the past. And thank you for all the work that you're doing to really open access to the Medi-Cal population and for the state of California. At White Memorial, we serve largely a Hispanic community. 88% of our patients are Hispanic, and most of our patients are very poor. The average income is less than $24,000 a year in our area. 53% of our patients are Medi-Cal patients, and about 34% are Medicare. So if you add the two numbers together, about 87% of the payments we receive from government. Basically, 87% of our funding really comes from government. So we go the way the funding goes. If the funding is there, we survive. If the funding is not there, our programs, our operations, and our community suffers when the funding is not there. You've heard of hospitals around us that have shut down, that have been sold, or they're being operated by investment and venture capitalists. Thank God today we're still running strong, and we have invested in our community the last 10 years, and we built a new hospital that's seismically very sound to withstand any earthquakes in California. The provider fee is critical to us. It's extremely critical to our survival, and it's very extremely important for the programs we provide to our community. I want to give you a few examples of the programs that we have that we can only do because of the support we get from the government. Folks, not every program that you do is economically feasible or generates return on investment for you. A lot of these programs that we do simply because they're very much needed in our community. The Hispanic community in Boyle Heights has 10 times the incidence of diabetes than the average in the state of California. So we have developed a diabetes program that brings in Spanish-speaking endocrinologists, couples them with nurses, dietitians, and other professionals to educate our community on diabetes. Now we have went beyond that, and we partnered with Telemundo, which is a cable company, and we have put our physicians on the cable news for 70 episodes to educate our community on diabetes, how to prevent diabetes, how to deal with diabetes, and it's been very successful. Actually, we did win an award from the Los Angeles Medical Association, Los Angeles County Medical Association, for being the most innovative in public education. We went a little bit further to deal with this issue, and we opened one of the first centers in the nation, what we call limb preservations. Diabetic patients suffer from extremities issues, from amputations, and it's not very well managed. So the limb preservation program is not like any other program in the nation because we put 7 specialties under one roof. So a patient comes in, they could see the infection control doctor, they can see the vascular surgeon, they could see the wound care specialist, they could see 7 different specialties all under one roof. And we did that to be able to preserve the limbs of patients with severe diabetes. We opened a Center for Hispanic Health that specializes in researching ailments for the Hispanic population as well. And we also partner with Teleco to train nurses that can deliver culturally sensitive care to our patients. You know, in the state of California, well, in Los Angeles, 48% of the population is Hispanic, yet only 8% of the nurses in the state of California are Hispanic. We partner with Teleco, and today I'm proud to tell you that 38% of our nurses at Hawaii Memorial speak Spanish and can deliver culturally sensitive care to our patients. One time, President Pro Tem de Leon was at our campus. He brought an older gentleman, 85 years old, to me. He said, "John, can you please help him?" The guy was in tears, didn't know what to do. He said, "I've been seeing my doctor for 20 years. Now I'm being told I can't see my doctor anymore because of the shift, in managed care that happened in the last year or so." So I took him to our information center that we opened on our campus specifically to help our community navigate the health system and be able to sign up for the right insurance so they could see their doctor and continue to manage, to receive the care they've always received. I can keep going on and on, program after program, that really are done for our community, that not really economically have a big return on investment, but we do this simply because we want to take care of our community. And we can only do that because the provider fee program that we have now. Without that, we really cannot continue to provide the care we provide. So I would very much urge you to please help us and support the initiative so we can continue to provide the care we provide. Thank you.
Thank you. We're getting close to the end of the 20 minutes. I give you a little bit more flexibility. I know we have 3 more speakers, but whatever time we go over, we'll allot the same amount of time for the opposition if they choose to take it. So just keep that in mind. Thank you.
Chairman Hernandez, Chairman Wood, members of the committee, good afternoon. My name is Chris Manson, and I'm the Northern California Regional Director of Government Relations for St. Joseph Health. And I'm here today on behalf of St. Joseph Health Eureka and Redwood Memorial Hospital Fortuna. As Chairman Wood knows, both hospitals are located in his district in the northern part of the state in Humboldt County, which has a population of about 135,000 residents. To say it's a rural area and to say it's isolated would be an understatement. It basically has 3 two-lane highways that feed that location, and oftentimes you'll hear people refer to the area as being behind the Redwood Curtain. In addition to being rural, it has a very high level of poverty. Many of the resource-based companies that once supported the area have left or gone out of business. In fact, 55% of the population makes less than 300% of the federal poverty level, making them eligible for some form of financial assistance outlined in our hospital financial assistance program. In fact, at St. Joseph Health, our financial assistance program goes to all the way up to 500% of the federal poverty level, and during the peak of this last recession, approximately 95% of Humboldt County qualified for some level of financial assistance under our policy. As of 2015, roughly 80% of those seeking care at our hospitals are either Medi-Cal or Medicare patients. Roughly 1/3 of Humboldt County is eligible for Medi-Cal. The remaining 20% of that population is either private insurance or has no insurance at all. So in spite of the overwhelming poverty, the rural nature of the area, and the overall payer mix, we are still dedicated to offering some great care at the communities we serve. The hospital fee program plays an important role in that effort and allows us to maintain the level of care our communities deserve. The hospital fee program has helped make it possible to bring the highest level of care to the residents of Humboldt County. And I will just take just a minute to highlight a couple of those programs. In November of 2012, St. Joseph Health Eureka opened its new 3-story state-of-the-art 100,000 square foot hospital with 138 beds and a 20-room emergency department. Some of the services provided at the hospital include cardiac surgery, cardiac rehab, a cath lab, children's and pediatric services, and a cancer program. I point all this out because without this hospital and these services, patients would be forced to be flown out of the area for some of these more critical services, or have to drive hours for care like those being treated for cancer. In some instances, in an emergency situation, this can be life-threatening. As you can imagine, it's also tough on family and loved ones who have to travel out of the area 3 to 4 hours to visit or transport sick family members or friends to the Bay Area or to the Reading, on 299 over to Reading. As more of these patients have had to rely on Medi-Cal, the hospital fee program has helped hospitals like ours by beginning to close the Medi-Cal gap in reimbursement. This influx of money has directly resulted in allowing us to keep these critical service lines open, which allow people to stay in our community for care. In addition to the core services that we provide, our Heart Center in Eureka has just been certified as a STEMI receiving center. This designation is reserved for the most severe heart attacks, which again means patients can be treated locally rather than having to be flown out of the area for treatment, which reduces the chances for poor outcomes. It's also the same, right now we're also in the process of standing up a trauma program up in Humboldt County. And again, without going through all the details or the rest of my statement, I'll just say, if you live up in that area, which I used to live up there, it is isolated, and if you do have a heart attack, if you do drive into a tree at 2 o'clock in the morning, you want to have care that's readily available. And the hospital fee program has been critical over these past few years to give us the resources that we need to stand up and maintain the level of services that serve those residents. So with that said, thank you.
Thank you, Mr. Chair. I'll be brief. Eduardo Martinez with the California Medical Association. Really appreciate the opportunity to speak. And I think for this initiative for our members, this was pretty much a no-brainer to come on in support. I think most of you know that we have ongoing concerns about the adequate funding levels of the Medi-Cal program, broadly speaking. We're concerned that we don't have the healthcare infrastructure to actually deliver on the promise of access to care that we've promised now upwards of 13 million individuals. And specifically what we mean is we're not sure that we have the providers always present to receive and to obviously give the care. About a year ago, we were here. It was a joint committee, joint meeting of both health committees examining the issue of Medi-Cal rates and access. And we had legislation on the table at that time, authored by Chairman Hernandez, that trying to bring Medi-Cal rates to a similar level to the other big government payer, which is Medicare rates. And at the time, that was a multi-billion-dollar price tag. Obviously, we weren't able to be successful last year. Hopefully, we're going to be before you later on this year to talk about other funding sources that will be considered. But certainly, we can't invest in the Medi-Cal program the way we feel like we need if we're talking about losing non-general fund sources, right? Which is a possible outcome if this initiative doesn't pass or if this fee isn't out extended. And to Senator Roth's point, I mean, we would be very concerned about the disappearance of $1.3 million to the general fund and obviously the federal matching funds that come with that and what that will mean for policymakers, for yourselves, about how to manage that budget shortfall. That's why we were very much in support of the MCO tax. We can't start talking about investments in the program if we're talking about losing money that we currently rely on, non-general fund money that we currently rely on. So thank you for inviting us to participate, and we're proud to be here in support.
Mr. Chair, members, Cesar Diaz on behalf of the State Building and Construction Trades Council. Our council represents 14 unions in the building and construction trades and about 400,000 members in the building industry. Our members are insured through self-funded trust funds. They're under a lot of pressures right now because of the ACA and the excise tax. They also see the pressures of the economy as it ebbs and flows. With regards to long periods of unemployment, a thought came to mind during the Great Recession of 2008. A lot of our members actually dropped off because there were not enough work hours to actually keep them insured. What happened was that they actually then had their children or basically their families get on Medi-Cal. This is going to be a big problem for a lot of individuals. $1.3 billion being left on the table or taken away from the general fund not only has a ripple effect for the services provided, but it sends a ripple effect through the construction industry as a whole. As you're contemplating investments in transportation, affordable housing, or other very important investments to deliver basically vital services to Californians, that will be impacted. The hospitals themselves, in terms of their seismic retrofits and the maintenance of these hospitals, they have to be constantly maintained, upgraded. Just the seismic alone is a huge investment to try to protect these from these natural disasters. There's about $8 billion type program and investment. If that is somehow hindered by the Medi-Cal fee not being available, these projects could either be long-term delays or just eliminated altogether. And all of that, of course, goes back to the quality of care and access to care but also in terms of building trades, our members being impacted by that. So we see the ripple effects to the construction industry of very closely. We see it as being very impactful, and for those reasons, we're proud to stand here in support of this measure. Thank you.
Thank you very much. Any questions, comments from any of the members? Yes, Senator Manning.
Thank you to all the panel members. I think I'll direct this question to Ms. McLeod with the Hospital Association. I think in your testimony in the earlier comments of LAO, a suggestion that there could be made modifications in the quality assurance fee under the parameters of this ballot measure. Is that correct?
That's correct. We see multiple opportunities where flexibility exists in the statute, which essentially is made permanent by a passage of the initiative. Not only does it give the legislature the authority to make whatever changes are required to obtain federal approval, but maintain that federal approval, in addition to being able to make non-substantive amendments. You can also make amendments that change the amount of the fee and the payment and the mechanisms that create the fee structure and the fee payment. So there's great flexibility, and changes are built into the statute that don't even require legislative participation, and that is that the program automatically right sizes. As more federal dollars become available, the fee program automatically grows under the department's authority to do so. And likewise, if there are changes at the federal level, the size of the fee program contracts to keep pace with what's available at the federal level.
But that's part of the existing formula?
That is correct. It's the existing formula, the existing statute, which essentially becomes the construct from this point forward upon successful passage by the voters of our initiative.
And what triggers legislative oversight over any of those changes?
So another thing that the construct going forward into the future does is it sets program periods. Similar to what we've seen since 2009, we've come back to the legislature every 2 to 3 years to seek a renewal of the program. That won't change. We're still going to every 2 years, at least every 2 years, no more than 3 years, have to redo and rebase the program. We expect there to be many changes that will be required within the industry, within federal rules, within some of the department's priorities to make those changes, and it would have to come back to the legislature during each of those rebasing periods.
Thank you. That's helpful. So, in other words, it doesn't establish an authority outside of the legislature for that oversight or approval of changes.
Correct. It only creates the timelines of the fee to be between 1 year and 3 years in duration, each program period. But once there is a change in the program period, changes will be required, and the legislature has the authority to make those changes.
Thank you. Thank you, Mr. Chair.
Thank you. Any other questions from any? Yes, Assemblymember Wood.
Yeah, and this is kind of a follow-up to a couple earlier questions around the hospitals that are not made whole, I guess. So what is the percentage of that? And obviously, it sounds like you've gotten the entire everybody to buy into this. So what are the percentage of the hospitals that are not made whole? And are they indeed parts of a greater system? For example, the 2 hospitals in Humboldt County, are they both made whole, or are they part of the system and one subsidizing the other?
So for example, kind of taking them in reverse order, the 2 rural hospitals that Chris represents, because they are rural facilities, the hospital fee program was structured in such a way that rural hospitals don't pay the fee, but they get the new payments. And that was the hospital industry's way of ensuring that any rural provider is not one of those that is harmed by what's called the redistributive effects of a fee. Now, with a hospital fee program, the federal government requires the overall program to be redistributive. That means they require there to be losers in a program. There are tens probably 40 or 50 hospitals that actually pay more into the program than they get back. The majority of those hospitals are part of a larger system that do well overall. We still have about, I think the number has decreased, we still have about 7 or 8 independent hospitals that aren't part of a system that pay more in than they get back. And we have one system that pays more in than they get back. But because this is so important to the hospital industry as a whole, the hospitals have taken the position, one for all for one, and they will not stand in the way of continued improvement for the Medi-Cal population. And it has been uncontested from day one and full support from all of our hospitals since 2009.
Okay, thank you.
Senator Thurman.
Thank you, Mr. Chair, to both Health Committee chairs. Just wanted to, about this measure, I do get that it creates tremendous revenue for us to use in programs that help children and draw down on federal dollars, and I understand create savings in the neighborhood of $850 million, which is great. I did want to just ask, as part of the measure, is there a request to provide less of those savings to Medi-Cal or children's programs? Because I've heard rumblings about people opposed to the measure saying that the hospitals would be, in fact, asking to give less money to programs. Could you speak to that so that we can have clarity about it?
Sure, hospitals are not in a position of asking the state to take less from the fee program to provide to children's health care coverage. We're very supportive. We're very proud of the program that we've crafted together. The legislation that's in effect now was SB 239 in 2013. And we're very proud of that partnership that was created. There is an incentive for the state to implement these programs to the largest size possible, because then the state shares at a percentage rate, not a flat dollar rate. So we want the program to do well, and the better the program does, the better the state of California does, and we're very proud to be able to offer those dollars through the fee program to the state to help benefit the kids. We've never asked for any of it back.
Thanks for the clarity. I'm just trying to get at what is it that's causing the heartburn for those who've said this is a bad measure for us. And just on the last point you made, does the incentive program for those hospitals that are able to be successful in getting the incentive, does the more incentive you get, does it have a negative impact on what's available for, say, children's programs or other needed health programs?
So I don't know what would cause somebody to believe that this measure wasn't good, because we see it benefiting everybody. We see it benefiting, first and foremost, the patients in the Medi-Cal program, which are now 1/3 of Californians. We see it benefiting the state of California, and the incentive, to be clear, is to the state of California, not to the hospitals. So the more advantageous the state can create the fee program, then the better that the state does in the program. The program itself, we're not aware of any organized opposition. We do understand there is some opposition today that is fairly new. Since 2009, the program has been unopposed. And when the current bill in its structure, which will become permanent with the initiative, when that was passed in 2013, there were no votes, and it was a unanimous pass through the legislature. So we too are perplexed.
Saying that the incentives are not tied, the incentives go to the state,
Correct.
And there's no correlation between the higher the incentive, the lower the direct funding that's available. You're saying the funding stays whole and there's no change as a result of the incentive formula.
The incentive formula is for the state, and any money that the hospitals received are directly correlated to care provided to Medi-Cal beneficiaries. The program truly was crafted in that the money follows the patient. There are no political or other type of schemes or mechanisms to divert the money in any way. It's aimed directly at patient utilization.
So the $850 million for programs doesn't decrease in any way?
It will decrease if the overall program size decreases, but we have found that the program is increasing every year, and what creates the size of the program, unfortunately, are the losses in the Medi-Cal program. And because Medi-Cal has paid the hospitals at a flat amount since 2009, yet costs go up, that delta grows year out over year, and the hospital fee is used to fill in that delta. So as long as the hospital fee grows, the incentive to the state grows as well.
Thank you.
You're welcome.
So a couple comments. I'm sure a question will derive from it. Obviously, well, first of all, thank all of you for being here, and in particular, Ms. Ann McLeod for putting together the hospital fee in the earlier iterations. As you know, obviously, I carried the last one or the current one. We all know that we're well underfunded in Medi-Cal. We have the hospital fee. We have the MCO. We're trying to do the tobacco tax to get provider fees, and yes, it's in the billions of dollars that we're to make us providers to at least get close to what Medicare is at $6 to $7 billion. And I guess my dilemma is that in the event that the initiative isn't passed, we have an one-year extension to allow the legislature to extend it, and then I'm assuming coming back to the legislature, I cannot imagine the legislature would not continue to do its due diligence to get the money back. Here's my question, just, thinking the initiative passes, it's written in the Constitution, and the federal government has changed the rules several times. Let's take the MCO tax, for an example, where we would tax just plans that took Medi-Cal. Now it's all plans, with Mary Cantwell did an incredible job. We came up with a mechanism. We were flexible. We did it through the legislative process. So I'm just thinking, what will happen? I'm just playing devil's advocate. If it's written in the Constitution and the federal government changed the rules so much that even what our limited scope that we can do in the legislature doesn't allow us to adjust, what do we do then? That's my dilemma. I understand you want to have it in perpetuity, but my concern is that now it's written in the Constitution. We have less flexibility to act. How are we going to, how do we address that unforeseen thing in the future? Do we come back to the legislature? Then you have to go back to the vote of the people, either 2/3 in the legislature. How do we address that?
So I think those are really great questions. And quite frankly, when we were writing the initiative language, we too put on our devil's advocate hat and said, how do we craft initiative language that essentially becomes permanent unless it goes back to a vote of the people and get such flexibility? Yet at the same time, we really want to protect the Medi-Cal program. Our biggest fear is that we go through another economic downturn. And when more and more people are relying on the Medi-Cal program, and if we go through an economic downturn and there isn't enough rainy day fund or anything else to bail us out, there is the potential, without the protections, that the legislature may be forced to take more of this fee money away, divert it towards the general fund or other programs, and take away from healthcare services from this Medi-Cal population when they need it most.
I get that,
we're
but
faced with that. So
I get that, but isn't that the responsibility of government to make decisions? And that's the decision that we may have to make, unfortunately, and choices. It takes we abrogate our responsibility as legislators, and obviously we won't be taking a position on this. This is a hearing. The people will speak. They'll vote it up or they'll vote it down. But I'm just thinking worst case scenarios, and then us as the legislature abrogating our responsibility.